Good morning, everyone, and thank you for coming. My name's Kathy Eastwood. I'm the research lead of the Libin Cardiovascular Women's Health Initiative, and I'm the Associate Director of the Center for Health Informatics here in the Med School. Today, I'd like to start with the territorial acknowledgement for the university that we are located in the heart of Southern Alberta, both acknowledge and pay tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, the Kainai First Nations, the Tsuut'ina First Nations, and the Stoney Nakoda, including Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also the home to the Métis Nation of Alberta, Districts 5 and 6. Today, for our Women's Health Research Seminar, I'll be introducing Kara Nerenberg. Kara is the Women's Heart and Brain Health Mid-Career Research Chair with Heart and Stroke and CIHR grants. She is a general internal medicine and obstetric internal medicine physician, an associate professor in the Department of Medicine, Obstetrics and Gynecology, and Community Health Sciences. She's a Libin Institute member within the Cummings School of Medicine. So please welcome Kara today.
Okay, can you guys hear me now? Yeah, okay. And I'll just see if people online can hear through Alina. I feel like I'm echoing, but turn that one. Okay. Okay, is that better? Okay, excellent. And let's figure out the tech here. Right. So, yeah, I want to introduce, since this is a research talk, I think I might need to take this off. I think, yeah, I think. Okay. Can you guys hear me though? Or is that, my voice is very soft. So yeah, I'll come closer to the mic. Let me just get this sucker out and figure out how we clickety click here. Yeah, okay. So because this is a research seminar, I wanted to take this opportunity to really try to engage some conversation on how we can do better in this space through transdisciplinary research and see if we can encourage some collaborations today as well. You'll see that I use this term cardiometabolic associated reproductive events, and I'm going to come back to why I've specifically chosen that term. Just wanted to give you a heads up that I came from a Mac to this, so my slides are a little bit off, so sorry about that. That's my fault. Alina wanted these before, but it's my fault here. So they look a little fancier because Judea here in the crowd actually helped me with some of the slides, but they used to look fancier. But in my own statement of reconciliation, as a settler on these territories, one thing that is really important to me and the team is that we try to reflect Indigenous culture, history, and ways of knowing and beliefs about health in our day-to-day work. And I think we still have a lot of room to go in that as well. I will try to use person-first and inclusive language in this presentation. However, I often use the term women, and I put a plus there, just recognizing that people who are pregnant are generally biologically female. However, they may not identify as being women. I often end up using the term women to represent some of the traditional roles and responsibilities that are associated with females in the reproductive years in caring for their young families and aging parents and whatnot. So if you have other suggestions, so we're really open to suggestions. No conflicts for today, but just to let you know, I'm involved in a lot of the different guidelines. And as Kathy mentioned, our research is mostly funded by Heart and Stroke and CIHR, as well as MSI, with a lot of support from Alberta Health Services as well. So by the end of this presentation, I still want people in this room, given that everyone's from different walks and different backgrounds, to really understand the different impacts of these common reproductive events on a female's future cardiometabolic health. I think many of us in this room may have had some of these pregnancy events like high blood pressure in pregnancy or HDP. gestational diabetes, GDM, or preterm delivery, or we know people who've been impacted, or we take care of patients who've had these reproductive events as well. So I think it's still important that we can kind of walk away with some simple management strategies, even though this may not be your clinical field, because we do encounter people in our lives in all of our different roles and responsibilities that we can share this information. But what I really want to talk about today is opportunities that we can do better in improving aftercare, or the care of people after pregnancy, through transdisciplinary research. And this really goes beyond the traditional interdisciplinary research where we think about, medicine, family medicine, obstetrics, thrombosis in the crowd here, nursing, midwifery, social work, psychology, because we really does touch on all these areas. But I want to start thinking about, how do we include our engineering collaborators, artificial intelligence, sociology, technology, and innovation in this space, and really work together across all 4 pillars of research, but also thinking further than that about health policy, education, quality improvement, et cetera, so that we can all contribute to advancing care. I think in this space, this is a really common slide that we use, talking about how women's cardiovascular health is really under-researched. And this came from the Heart and Stroke Report in 2018. And I think no one in this room is a stranger to this, or the fact that your area is likely underrepresented and under-researched too. But we do know that in terms of cardiovascular disease in women, one of the things I do add is that we probably are under preventing it. We have this tremendous opportunity to identify women earlier in their health journeys around the time of pregnancy, and use that as an opportunity to prevent future cardiometabolic conditions if we layer in preventative interventions. So real missed window of opportunity there in general. I always love this slide here of our patient partners who have lived experience. Has anyone in this room actually seen this documentary, The Atypical Heart? It's a bit of a play. Oh, hi, Don. Hi. It's a bit of a play on words in a lot of ways, because we think about like atypical chest pain, but it's actually typical. And so the reason why I love this video is because it really centers around the patients, or the people with lived experience. And our research really does too. And when you actually watch this documentary, it's tremendous. It's done by an Alberta-based filmmaker out of Grand Prairie, and a lot of different, Alberta-based researchers and patients are interviewed in it as well. But these women, they're powers. They're just so powerful, and they share their journey and they share their experience with us. And a couple of things that really come out is almost all of them had a pregnancy-related event that increased their risk. What we also start to see is that they start to accumulate heart attacks and strokes in their 30s and 40s, leading to premature death. One of our patient partners, he lost his wife about 13 years after delivery. And again, really probably could have been prevented. But what's also a real challenge here is they identify that they got no follow-up care, no education, no support for their health behaviors. And I don't know how many of you in here have kids. I have 2 small kids. I know Leslie does as well. But it's impossible to fit in health behaviors, physical activity, nutrition, when you've got kids who won't eat things, or how do you get to the gym? So again, like, how do we do better in this sport here? But also what really came out in their stories is postpartum mood disorders. So for people working in the mental health space, how do we address those in a way that allows women to engage in positive health behaviors? Finally, the big thing is the fragmented care, and that's what I'm going to focus a little bit on today as well. So many of us have seen this slide in this space, and it was a CHAMP study. It was looking at cardiovascular health after maternal placental syndrome. So that's really looking at the placenta and preeclampsia, those high blood pressure conditions. And that's a really diverse disease. And what they did is Dr. Joel Ray, our colleague out in Toronto, using Ontario data from ICES, just sort of mapped the health journey after pregnancy, and split people into kind of the lower severity of preeclampsia diseases and the higher ones. And what you can see here is following them out up to about 10, 12 years after pregnancy in young people starting to see an accumulation of early cardiovascular events. So this was real heart attacks, strokes, mini strokes, admissions to hospital for it. And what you can see by any type of preeclampsia or hypertensive disorder of pregnancy, we see this dose response relationship by severity. So the less severe, what we call non-severe, about an odds ratio, a hazard ratio of 1.8, and the real severe patients who have preeclampsia with fetal death had a 4.4 times higher risk of premature cardiovascular disease. And this was true across any vascular bed, whether it was the brain, cerebral vascular disease, heart attacks, and peripheral arterial. And that's one thing we forget about all the time as clinicians is like intermittent claudication and the need for amputation and surgery there. But I'm going to provide things to two things that really shocked me about this is that the average age of the first heart attack or stroke was 8.7 years after delivery, an average age of 38 years old. Okay, so just going to stop there. 38 years old, and our women in our community are having heart attacks and strokes. But one that makes me even a little bit more nauseous is that this information down here in the bottom, where's my little mouse here? Well, I don't know where the mouse is. Down here, 2005, top medical journal in globally, the Lancet, 2005, it's 2025. And I challenge you to think about how much have we actually moved the needle on care for these women in 20 years since this landmark trial. Since then, there's been tons of papers showing the same relationships as well. So what am I doing here? Okay. So not only are they having heart attacks in their 30s and 40s, but they're actually dying prematurely as well. So this is US-based data because again, we don't have this in Canada, so we have to use US. And I want to draw your attention again to the same kind of relationship. Came out in 2010. So 15 years, where are we at now? I don't even know, 15 years ago. and what you can see here is survival to 30 years after pregnancy in people who've had severe preterm preeclampsia is only 86% at 30 years to an average age of 56 years old. So we have women in our communities in Canada who are infarcting in their 30s and 40s and dying prematurely in their 40s and 50s and 60s. So, and our patient partners are telling us this. Our patient partners have these stories that they have shared with us so that we can do better. The reason why I call these care events is because of all of the cardiometabolic associated events that come with this. So it's not just the vascular damage from head to toe, but it's things like hypertension that rapidly develops. We know coronary artery disease, cerebral vascular disease, arrhythmias for the arrhythmia group in here, atrial arrhythmias, ventricular arrhythmias, heart failure. Okay, so heart failure is actually really shocking for those working in heart failure because they had a 4 times higher risk of heart failure within the first 4 years after delivery. And this is not peripartum cardiomyopathy, okay? This is different entities here. Premature cardiovascular death, all-cause death, all the microvascular from head to toe, so speeding up, accelerating dementia, kidney disease. We found seizure risk as well in this group. And then all the other traditional atherosclerotic risk factors of diabetes and dyslipidemia too. So again, I've stopped using the term APO or adverse pregnancy outcome because it's not a correct term. First of all, it's not patient-centered and patients don't really like it, but it doesn't actually describe the pregnancy events that we're looking at because we do know that it's beyond just pregnancy. It's all the reproductive time. So the hypertensive disorders of pregnancy or preeclampsias have the highest risk estimates of future cardiovascular disease and death. And then we also see preterm delivery, stillbirth in there, placental abruption, gestational diabetes, a new emerging area of severe maternal mortality and severe maternal morbidity, which is this huge concept evolving. But we also know that it's the fertility journey too, PCOS, infertility treatments, and then even postpartum preeclampsia, and then lactation, whether or not lactation actually lowers the risk of Oh, I see. I got to change breastfeeding, sorry, to lactation. Sorry about that. But we need to really think about it in terms of the whole reproductive journey here, and that these are not just adverse pregnancy outcomes; they're a long-term consequences, which is why sort of trying to coin the term CARE, cardiometabolic associated reproductive events. So what's the link here between these pregnancy events and future cardiometabolic health? Well, I think the simplest one that we often talk about is that pregnancy is somehow a stress test, that it kind of unmasks people who are on this pathway to developing these cardiometabolic risk factors. And we know there's a component of that that is true based upon epidemiologic data, clinical studies as well. And then through mathematical modeling, a group over in the Netherlands found that if we actually treated all these risk factors after, that we can lower about 90% of the risk of premature cardiovascular disease. But so that remaining 10% or more is likely due to the direct effects of endothelial dysfunction that occurs during pregnancy, whether that's from the high blood pressure, because we know that preeclampsia is kind of shredding the endothelium of the blood vessels from head to toe, and as well with gestational diabetes, we get endothelial dysfunction. And it's thought that that might either initiate atherosclerosis or kind of speed it up in those who already went into pregnancy with components of metabolic syndrome and early atherosclerosis. But what's really cool, and I think we're showing this with some data that Kathy's team helped us get, is this concept of accelerated aging through lab models in the US. Dr. Garevich's lab has shown this concept that this pregnancy is kind of accelerating the aging, the hits on the biology and cell death and inflammation are actually probably accelerating. And this explains why we're starting to see multi-morbidity within the same person. I think what's completely left out of all the research today is the intersectional determinants of health on cardiovascular health, because we know that socioeconomic status, these gender roles and responsibility and ethnicity have tremendous impact on cardiovascular disease, and we need to do better in this space. We're working with some people that are real leaders in this space as well. And then for those in the room who, like Dr. Thompson, are working on the in utero programming, is how do we actually change then the health for the child afterwards who has experienced an in utero environment through gestational diabetes or preeclampsia that's also putting them on this pathway to premature cardiometabolic disease. So it's important that we take these mechanisms and then think about really simply of how do we then manage women lifelong. And this is where, again, we really need to do better. So when we group this together, really simple slide for a review article that we did, looking at, again, okay, so development of cardiovascular risk factors. So we need to screen for cardiovascular risk factors. Like every time we go to our doctor, we get our blood pressure checked. We start getting our cholesterol checked after 40 sometimes, diabetes screens, et cetera. And so how do we really screen for that and then manage? And we really want to layer in prevention early after pregnancy, starting to think about counseling on all those health behaviors that are really hard to do. So physical activity, 150 minutes of moderate to vigorous physical activity a week, healthy nutrition. But again, we need to do better than just that as well. What's really missing is some mental health support. We don't have targeted therapies of, again, how are we going to address the vascular and cardiac dysfunction that happens during preeclampsia and all these conditions? Should we be starting ACE inhibitors, ARBs? Should we be thinking about statins really early? We're using that for prevention of preeclampsia now. What about some of the newer agents from the obesity world? Because we do know that these women rapidly accumulate obesity as well. But again, what we're missing from this is really kind of gender specific, race, ethnicity specific. How do we actually include these in our management plans for patients? So if you're going to leave, that's okay. You can go now. You kind of learned a little bit about these reproductive events on future health and can share with people in your circles, hey, maybe you should go see your doctor and get screened. Your doctor might not know, but, I saw this presentation. You should go just get checked out. And then for those who've had these pregnancy events, starting to think about, maybe I should see my doctor and think about maybe, my cholesterol is high. I think I do need to go on that statin, et cetera. But this is the goal here in this room and through Libin today, is really talking about opportunities for transdisciplinary research to improve the aftercare. What happens after these events? So I'm going to use some of our research, but also some research from collaborators around to really emphasize how, if you're looking for a field, here's a field that has lots of research gaps and really needs that transdisciplinary research approach. So how do we close this evidence to practice gap, right? So again, as researchers, it's not enough just to come up with, some evidence. We got to implement that into clinical practice and then evaluate the ongoing impacts of this. And this is where the real learning health systems approach is critical for research. I think there's so many good interventions out there that aren't getting into practice, and Alberta is uniquely positioned to excel in a learning health system through our previous SCN, Strategic Clinical Network, and now the PINS, where we take the three components, evidence and best practice, we implement it into integrated care at health systems levels, and then we use data and precision medicine to kind of reevaluate how this is going. And it's very cyclical. We need to do this on an ongoing way, and I know Dr. Eastwood's team is really involved with this as well. But we also need to start thinking about, okay, we're coming up with these cool ideas. Maybe it's a risk prediction chip that I know people around here are working on. Maybe it's a risk prediction model. But how do we implement it? Are we actually going to affect the quadruple aim of healthcare improvement? If we want to get things funded, we have to now, in this day and age, show that we are impacting the quadruple aim of healthcare improvement. And so that involves improving the patient experience, healthcare provider experience, improving patient outcomes, and positive and negative, and lowering costs. But for this population, we have to add in something else. It's these transitions in care across the continuum of their life, from preconception to postpartum, or pregnancy to postpartum, but also their transitions in care across specialties, going from obstetrics, where we identify them, or midwife, like obstetrical related care, whether that's a family doc, midwife, or obstetrician, then going into specialty care, transitioning back to primary care. Primary care is really at the foundation all along, and then prevention. How do we continue the focus with prevention? So what we did is we really wanted to start transforming Alberta's health system. And this takes a lot of work. And we've had some amazing partners through the Center for Health Informatics with Kathy Eastwood's team, as well as the Strategic Clinical Network. And what we first did is created a cohort, a data to show, let's survey the cardiometabolic health of Alberta females over the reproductive years. And in that way, we can kind of do a couple of things. We can look at opportunities of where we can layer in prevention interventions, and then also assess the impact of it and really create a learning health system. So Kathy's team helped us create this using all the admin data here in Alberta, which again, we're very rich at, involving inpatient, outpatient, drugs, labs, and the perinatal registry. And we ended up having over 300,000 deliveries, and we followed them up to about 10 years. And hopefully we can refresh this later and get about 3 or 4 more years of follow-up for these patients as well. But what we really want to do is show the health of our population, and it's not good. Okay, so period. It's just not good. So the main findings from this I'm going to show you today are things we need to change. So the biggest thing when we looked at this was, holy doodle, we have had in a 10-year period a 25% increase in these conditions, from 18% of all pregnancies to 25. So that's like 1 in 4 pregnancies in Alberta, sometimes round down to 1 in 5, depending on who I'm talking to, but have a cardiometabolic associated reproductive event. So think about this tsunami of chronic disease that is coming down the pipeline. And this trend is continuing to go up. The epidemiologists in the room are going to say, well, the definitions changed a little bit. Yeah, they did, but still, it's still going up. And they didn't all. It's not only due to age, and it's not. So, certainly we could look into this a little bit more. But what is shocking to me as a clinician scientist is that we have many evidence-based interventions to prevent these events, and they're clearly not getting into clinical practice because it should be going down if we were actually implementing what works. And what also from a health systems perspective we have to think about is this enormous challenge to see 11,400 women each year with preventative interventions. And again, we have 3 specialty clinics in all of Alberta, so clearly we cannot see 11,000 women each year. And how do we really engage with other ways to do that? So again, these events are going up. We're all going to come across them in our personal lives and in our professional lives as well. So the good news is there's a lot of evidence-based interventions to prevent preeclampsia. So we have good data from clinical trials about aspirin, physical activity, calcium intake, and time delivery. And then epidemiologic kind of shows some other trends of pregnancy interval spacing, weight loss between all pregnancies to lower that to lose the baby weight that most women retain lifelong in this group, and the use of prenatal vitamins. So I'm going to focus a little bit here on the one in the middle of aspirin. We got hematologists in here who loves aspirin too. So we all love aspirin in this room. So, but how do we implement it into clinical practice? So I don't see any obstetricians in here, and they might be online, but the randomized control trial that showed a reduction in preeclampsia used this really cool algorithm a risk prediction tool to identify people who had high risk. So that's this right here, if my mouse is working right, is this risk prediction tool called the Fetal Medicine Foundation algorithm, which you have to pay for. Okay, so the majority of obstetricians do not use this algorithm when we're trying to figure out someone's risk and whether we should put them on aspirin or not. So right away, you got a barrier to care there. You have to pay for this. So Dr. Joanne Johnson from Maternal Fetal Medicine here, who many of you know, collaborated with them to integrate this into the first trimester screen when women are going for their, so how do we standardize care? We add it on to standard care. And so she was able to implement here in the Calgary area through an implementation study, implement this, and then put women who are on high risk onto aspirin. And this is just like one of my favorite studies is that she had a huge uptake of patients. 98% of patients agreed to do this. They actually agreed to have extra blood pressure measurements and whatnot, because this isn't just a checkbox like on a piece of paper you can give. You have to do blood pressures, you have to do uterine artery Dopplers on it, and you have to have blood tests for this algorithm. So it took an extra 2 minutes to do these Dopplers, and in total kind of counseling patient through, it took 6 minutes. So it added 6 minutes onto time, 8% screened positive, and it did identify those with preterm preeclampsia. Again, the second part of this of getting them on aspirin is a little bit more challenging because it wasn't done through the clinic. It was done through an extra step, which again, we need to address that extra step to try to reduce that. But when we think about the quadruple aim, this was shown right here in Calgary to be acceptable to patients, acceptable to healthcare providers, and start to improve outcomes with preeclampsia. And as we get more data, we can actually show that as well. So again, how do we then roll this out across Alberta to other first trimester ultrasounds? When I do calls across the country, other centers, provinces and cities aren't even putting people on aspirin. So again, missed opportunity for prevention. Now, what about data? We got to talk here. So, I just wanted to go back here. So, again, there's a role here for precision medicine to make these risk prediction tools better. Engineering, I know, is working on maybe could we think about a chip? Could we, with our lab colleagues, there's some great work going on looking at, can we do a biomarker that's going to accurately predict? Go at it. There's a prize, like a global prize, whoever can predict preeclampsia. So data. Okay, so what kind of data do we need to show that we're doing better? And a big issue here is when we take women throughout this journey, and I'm going to show you their journey, it's messy. And there's lack of standardized indicator at different levels, whether that's the clinic level, hospital, provincial, national, and global. But there's opportunities here to start thinking about how we standardize it. So we're looking nationally at setting the indicators that we want to collect through what's called a common exercise to standardize outcome collection in this space. And Dr. Isabel Malhame, who some of us in this room knew, she kind of went through a process here of when we think about severe high blood pressure in pregnancy, creating some of the indicators for treatment of high blood pressure at a hospital level. And again, we really need to be doing this at every step of the way and globally moving towards the World Health Organization HEARTS model as well. So I always say that so many of the great questions come from our trainees, and from the trainees in this room, you're going to see how it was the trainees who identified these questions. So this is Dr. Haley Lefebvre and Dr. Taylor Bahan, who were first-year residents at the time, and they noticed a huge number of women that they delivered with who had high blood pressure in pregnancy came back to hospital, and they were readmitted in that first 6 weeks. So Kathy's group helped us look at these readmission rates in 6 months. Again, we could probably go back and tighten that up in the first 6 weeks postpartum. But look here, 6% of moms who have severe, so in general, 2% get readmitted after pregnancy. And then when we look at kind of people with gestational hypertension, 4.5%, preeclampsia, 6%, and severe 5%. So this is a huge number of hospital admissions every year in Alberta that is largely for blood pressure management postpartum, because the blood pressure goes berserk after they deliver. It goes up, goes down. It's a mess. Ainsley, Dr. Ainsley McBride, who has just finished her specialty training in obstetric medicine, wanted to also look at like, where are they going for their care in the outpatient level? And this is here for anyone in the health system. 33% are going to the emergency department in the first 6 months after delivery. So that's the wrong place for them to be going with a brand new baby. Think about the burden on our emerges for preeclamp, and the large majority of this, again, is blood pressure related. There's also wound infections and whatnot. But this, if we can reorganize the care, think about the cost savings to our system just from the emergency department alone. 90% see a family doctor within the first 6 months. And that probably reflects the fact that 10% in Alberta don't have a family doctor, at least that or more. And so again, we can't only rely on women to be seeing their family physicians for this. And then specialist visits. Here you can see a lot will interact with specialists, whether that's myself as an obstetric medicine or general internist. It might be a kidney specialist, might be a heart specialist. But again, so they're going to different places in their health journey here too, but really high users of the health system in that first year after delivery as well. Kathy's team helped us get the number of visits, which I'm not showing you today, but a lot. So how do we do better? There is evidence out there that postpartum blood pressure monitoring works. And everyone in this room is going to say, yeah, of course it would work. Why aren't we doing this, right? Like, so yeah, why aren't we doing this? So that involves sending a woman home from hospital with a blood pressure machine so she can monitor her blood pressure at home. If it starts to spike, she can follow an algorithm to increase her blood pressure meds. As I said, that first 2 weeks after, blood pressure goes really high and then it starts to go down. This is when they come back in that postpartum period because they have a headache, they have brain edema, they have heart failure and whatnot. So how do we do this in a way systematically? We know through randomized controlled trial data that blood pressure monitoring works. Maybe we can think of a better tech solution here in Alberta to create a blood pressure program, again, adapt what they did in the UK to the local context here. But this is an incredible opportunity here because what they found 9 months later, okay, so the women had blood pressure titration for only about 6 weeks or maybe 3 months. But then what they did is they followed them 6 months later to 9 months, and the blood pressures were still split. So that tight control of their blood pressure actually had major impacts on their diastolic and systolic blood pressure. We now know from other studies too, following at 4 years, there's still improvements on their heart echo function too. So these small amounts of blood pressure are huge at a population level and at an individual level too as well. So again, from like the implementation side, they did it. They recruited 221 patients really quickly. And they layered in really important secondary and tertiary outcomes into the study. Love this study. And my take-home message is that this should be standard of care for home blood pressure monitoring after delivery and even during pregnancy. And I'm going to show you why as well. And again, from the quadruple aim, it improved the patient experience, improved the healthcare provider experience, it improved outcomes short-term, and it's going to improve in long-term. And as a result, we're going to see a cost saving. So how do we implement this in Alberta? And here in Calgary, We collaborated with the South Health and the Virtual Hospital at Home program to do this with community paramedics. Up in Edmonton, this is the Edmonton group with Dr. Greg Ventushin, looking again at postpartum management through the Virtual Hospital at Home. We have technology, we just need to use it, okay? So right now, they've done tremendous work on this. They've had hundreds of patients enrolled in this program, and now we're in the evaluation stage to really see, are we checking off the boxes of the quadruple aim? And then how do we learn from their implementation to roll this out across Alberta? Because it should be standard care. Okay, another amazing trainee, Jennifer Lee, who's now in her first year of obstetrics, wanted to look a little bit about like which women do we focus on after pregnancy? We have 11,400 women each year. How do we focus on them? And what she found through Kathy's team's data was that multimorbidity, 2 or more conditions cluster in women who've had high blood pressure after pregnancy. And so again, when we kind of mapped this out here, if you look on the right, that at 10 years after delivery, so remember these women are only in their 30s at this point, maybe 40s. I guess I would have been in my 50s, by 10 years after delivery, half of the women with preeclampsia have more than one chronic condition. So these are people that didn't have them before. And about 20% have 2 or more cardiometabolic conditions. So this means obesity, diabetes, prediabetes, high cholesterol, high blood pressure, heart attack, stroke, everything there as well. And that it was a really early onset. The average kind of events were happening at 5 to 6 years after pregnancy. So again, most of these risk factors are largely preventable through early education, screening, and health behavior supports. So how are we doing for screening? This is Dr. Chuan Wen in the middle, who did her PhD with Dr. Anderson and I and her committee here, and looked again at a provincial level of how are we doing for screening. And Kathy's team helped us look at this for a longer duration with bigger data, but I just want to look at the percentages here, okay? So we won't look at the absolute numbers, just the percentages. But you can see here, screening for high cholesterol after pregnancy, we're only screening about 50-ish% of those women that probably need to be screened within the first 4 years to see if they actually have high cholesterol here. But we're actually, of people with normal blood pressure, these are the young women, we're screening 40% probably of the wrong women too. So good opportunity here for reorganization of limited resources here. But what we saw with the cholesterol over to the side was a dose-response relationship in the level of cholesterol by the severity of preeclampsia as well. She did the same thing for looking at prediabetes and diabetes screening. And again, we found that we're probably not screening enough women and that we're probably screening the wrong women. And again, a dose response relationship of any measure of glucose, so whether that's our A1C or our glucose levels by severity of preeclampsia. So about 60% had another glycemic test. And this one's tricky because some of them will be having another pregnancy. But a really high prevalence at 4 years after the delivery, 7% had a form of prediabetes or diabetes. Yeah, not good. So where do we go from here? Is that how do we get this into clinical practice? And this is a challenge with knowledge translation for those of us in here who are working on knowledge translation. Great frameworks from CIHR on gender-specific KT frameworks, but the guidelines are a bit of a mess, and I can own this because I think I contribute to all of these guidelines, and they're a bit of a mess. And how does a primary care provider read all 8 or 9 of these guidelines? And then also the clinician resources, they're kind of a mess too. They're all over the map. There's so many. Do you look at weight related? Do you look at blood pressure? Do you look at, what do you look at? And then think about what's coming to the patient, either nothing or too much. So, great resources by Margie Davenport up in Edmonton on exercise and pregnancy, but are they being used? What about these apps? Like there's so many apps coming at patients. So again, how do we really do this and get the message out to the right people? So our group is really working on how do we do that we brought together through the chair I hold, clinicians, researchers, patients, health systems people from over 25 clinics from across the country. It started off as 12 when we started this about 6-7 years ago, and now we're up to over 25. So we're getting some momentum here of people starting clinics. but we really want to look at what are the best practices to care for women, because there's not a lot of evidence right now. And then how can we collectively start collecting this data to really show what's working, different models of care and whatnot. So again, from a precision medicine perspective, this is going to be a really rich data set there. So the first thing that we've done, the slide's blurred intentionally, is we created a new clinical practice guideline. It was like a 5-year process, gave me a ton of gray hair, but we really did this in a really rigorous way to not only review the evidence, but to incorporate patient-centered considerations. Because if we want to change care, we need the patient voice involved. So the patients were involved in this guideline and really talked about principles of shared decision-making, individualizing the recommendations based upon their reproductive plans. I'm not going to start someone on a statin if they're going to have a baby, like they're going to have another pregnancy in a couple months, and I'm not going to put them on an ACE inhibitor too. I'm going to continue breastfeeding friendly medications and stuff. But what was really key was understanding the patient experience, the birth trauma and PTSD that these individuals had, and also what their personal health goals are too, and how do we let them prioritize their own goals. So this should be coming out later this year. CMAG has been very supportive of us. But again, how else can we do better? So from a health systems approach, we created an order set. We took an opportunity with Epic, the new Connect Care electronic medical record that got rolled out across the province that many of us love, many don't. But we took that as an opportunity to integrate an order set of management of high blood pressure in pregnancy, and then also a reminder that at discharge, these women need to be connected with follow-up care. So that's a little soft, that order there, because it's within the local context. So we need to take a chance to go back and actually look at, is the order set being used? How do we really use that after visit summary that everyone walks home with? And again, we've spent a couple of years working with Connect Care on this, and Judy and I actually both have a lot of gray hair for this, I'd say, and whatnot. But again, this opportunity to standardize care. When I talked about the postpartum journey being messy, I really meant, the pregnancy journey being messy, I really meant that. This is Dr. Anmal Shahid and Dr. Joe McIntosh. Anmal is a Health Systems Impact Fellow, and Christian is a research scientist within Alberta Health Services. And what we really wanted to do is look at the journey of women. So what are their touch points with the system? And so again, we did the quantitative journey mapping with the admin data, and now we're looking at their patient experiences and whatnot. And how do we create a pathway where we can go and reach women where they're at? Because what we see in Alberta, so we put this visual together that when we discharge women from hospital, we lose them at every step in their journey. We lose 25% from discharge to a specialty clinic referral. And that's people who accepted a referral for one of these clinics in Edmonton. And then by the time we get them out to cardiac rehab, for those involved in cardiac rehab, we're down to fewer than 10%. So we're losing them out of the pipeline. And when we ask women why, they tell us about the barriers to care. So competing demands, gender-related responsibilities, family responsibilities, mental health, a lack of knowledge and whatnot, and really the fragmented transitions in care. So our goal really is how do we use the health system to go to them and reach them? And when we did our systematic review for the guideline, we found some best practices of flagging people in the electronic medical records, standardizing these transitions in care, automatic reminders like you get for your pap smear or your colon cancer screening and whatnot, and really how do we support in a family-centered approach. We looked at the specialty clinics here in Calgary, the Prevas clinic, and that's Dr. Kimberly Nix on your left, who was a CIP trainee who passed away of sarcoma. And she did an amazing job, not just advocating for cancer patients, but really looking at what was the patient experience. And we know that a one-time visit actually changes health behavior. 95% of women who got counseled about their future risks changed one health habit, which is huge. I don't think I've changed many in my whole life, but anyways, but 95% actually made small changes. Is it sustainable? I don't know. So where we went from that is we looked at, again, a health coaching program. We looked at how do we support women in clinic with a health coaching model, because we all know that you need a little bit of a cheering squad to really keep going with some of these things, because they are hard, especially when you have a young child. And this is a really special slide to me, because the patient sitting here who allowed us to have her story told and her picture, and who participated in the health coaching program, made tremendous impacts. She actually lost her sister Kara to HELLP syndrome 7 years ago. I'm not sure if her mom Jill is on the phone right now by Zoom, but Jill has been a fierce advocate for blood pressure monitoring in pregnancy, and how we can do better to prevent more maternal deaths. Maternal deaths happen in Calgary, and they shouldn't be happening in pregnancy. We looked at different models of care, again, looking at virtual care for those who are interested in that space. Judea and Justin were working with us on a bigger virtual program that we've had to table for a while. Risk prediction, we can definitely do better there. Really starting to think of it from a different lens, though. We can't predict 30 years from now right now, but we can predict the next year. And we need to think about how we use information we have at hospitalization to identify who we need to see in that first year. So again, I think in Alberta, we can really work towards that kind of a rec. I want to just close with this one here. Again, if we are going to improve aftercare and heart health for these women, we need to really start thinking at multiple levels. And we've collaborated with Dr. Ann Peterson from BC on how do we actually integrate a gender transformative framework. And so by this, it doesn't mean that we change people's gender identities or anything. It means that we reduce barriers to preventative care through health policy and whatnot. So we think about gender sensitive interventions, gender specific and gender transformative, and how can we actually support women, not just in the healthcare system, but in our communities through, policy level changes. Paid daycare, that's a big one that's coming down the pipeline right now. Longer parental leaves, medication support as well for some, like diabetes is doing a great job of getting some of theirs covered too as well. So again, from the sociology perspective, we do need to think about the impacts of gender in how we build our models of care. So just to summarize, we have every year 11,400 pregnancies, so 1 in 4 or 1 in 5 pregnancies. These individuals are 2 to 4 times more likely to develop premature cardiovascular events, 30s, 40s, 50s, and premature death, and preventative care after pregnancy is not standardized. There's a lot of evidence out there about little individual things, but how do we pull it together and standardize that postpartum transition and care to set people up for a successful health journey? So this is Dr. Brianna Galley, who is now at McGill in first year obstetrics, who did this policy brief that we were able to pass on to the government. So tons of research opportunities there for us. But what we really need, so we summarized a whole bunch of research gaps amongst that are needed there. Again, it comes up as top from international organizations, Canadian organizations, the Libin research priority setting. But how do we do this? And we can't do it in individual silos. And I think this is why we're not moving the needle on care. We need to start thinking transdisciplinary, really following a learning health systems approach, thinking about how we're going to get those new innovations into care at the get-go, starting to plan if we want the health system to adopt it. We need to start checking off the quadruple aim and start really thinking about the transitions in care. So with that, I'll thank some clinical collaborators across the country involved in the CPCN and some local and national collaborators, and I'll take any questions.